to start out by talking about metastatic hormone-sensitive prostate cancer and how we use our diagnostics like imaging and genomics to categorize our patients and select treatments. So we did hear the STOPCAP meta-analysis that mainly looked at clinical features. Was there anything you found interesting there? Anything new?
Yeah, I'll take it. I thought the most interesting component of that meta-analysis, I think as you highlighted well, was looking at the age component and how patients did with abiraterone versus the AR antagonist based upon age. And I think we saw that old patients over the age of 75 seem to have inferior outcomes with abiraterone compared to the other agents or compared to younger patients.
Yeah, obviously that raised a bit of concern, but one of the questions towards the end raised geriatric oncology. Is that something that either of you have access to or utilize much in your clinics?
I don't really use geriatric oncology particularly, and in New York I would say that the people that are in the geriatric range come in and want to do everything that they can do, but after listening to you and listening to that analysis, it seems that the older patients can do just as well, perhaps on ADT, and they don't necessarily need to have a second ARPI. I see patients in the 80s and 90s who really want to do everything in Manhattan. It's different than what I saw when I was in Rome, Italy.
I think age is a tough variable, right? You know, sometimes we meet a 75-year-old that seems more functionally like a 90-year-old, and sometimes we meet an 80-year-old that's just as active as a 50-year-old. So I don't know that that's the best tool to help us make decisions about treatment intensification. It's a component, but I don't think the most important component.
I would agree with you on that one. I really would.
Yeah, and
It's
yeah,
biological age, right?
Well, yeah, I definitely agree as well, and I think a lot of it is also, patient-driven, also, based on patient preference and sort of how much they're willing to do and how much, what their expectations are. And some of that is age-related, but much of it is not.
I think older patients will have other comorbidities such as cardiovascular disease, hypertension, diabetes, and they're on an average of 10 drugs. So that probably has to be taken into account.
Yeah, I think that's a very simple tool that the VA has developed. That number of medications that a patient's on is so predictive of longevity, and maybe those are simple things that we could be incorporating when we're trying to decide. What about disease burden? Like if you saw an 80 or 85-year-old with a lot of disease, does that make you more want to use a doublet, perhaps?
Perhaps a doublet. I wouldn't necessarily use a triplet in an 85-year-old, but I would if it was a 60-year-old. I would want to use a triplet if they had lung disease, liver disease, or a lot of disease burden for sure, or if they had poor histology, Gleason 9. For sure.
Now in Europe, they probably use more PSMA PETs than we do here. Are you using PSMA PET to gauge disease burden in your metastatic hormone-sensitive prostate cancer patients here in New York?
I work in New York. In New York, we do a lot of PSMA PET, particularly if patients have biochemical relapse, and perhaps patients are the first time they come in with metastatic disease. But I think that there's not enough data to use PSMA PET to follow our patients. They're still followed with conventional imaging. We don't. Nuclear medicine people love PSMA imaging, and they say we should follow everybody with PSMA imaging, but we can't do it. The insurance doesn't pay for it, and there's not enough data out there doing that.
Oh, I was just add layer on to that. I think it's a useful staging tool, kind of depending upon what you find, especially in the de novo space with conventional imaging. If you find high volume disease by counting lesions with conventional imaging, I think more often than not, the PSMA PET's probably not going to change my behaviors thereafter. If I go from seeing 10 metastases to 20 metastases, I don't know that changes a whole lot. Whereas I think, and there's no data to drive what we do in these scenarios, but when someone has a CT cap and a bone scan and you only see one lesion, and you're thinking about now kind of this whole smorgasbord of, am I going to radiate the prostate? Am I going to do metastasis-directed therapy? And all these questions that come up. That's where I find the PSMA PET can be helpful, because you can get an idea of kind of what is this the tip of the iceberg, or is this actually all that I'm dealing with?
I find it's more common in my practice actually for PSMA PET to be the first form of staging that patients have by the time they're coming in. And we spend a lot of time thinking about, oh, is this patient high volume or low volume, and how do we extrapolate from the PSMA PET scan to conventional imaging? But I find that most patients aren't in that gray zone, right? You either have a patient with a PSMA PET with a lot of disease and you recognize this is going to be a really aggressive biology, or you have a patient with a PSMA PET scan that has just a few bone lesions. And you know if they've only got a few lesions on PSMA PET scan, they're going to be low volume disease if you were to have conventional imaging. And so we spend a lot of time thinking about, well, how do we parse it back and forth? But I don't think it's applicable to most patients.
Also, the studies that we have are all done with conventional imaging. When we design, to talk about the charted study in high volume and low volume, where it was first talked about, that was all done with conventional imaging. The EMBARK study, the charted study, all the studies are done with conventional imaging. So just, you can't really extrapolate from the PSMA PET.
Yeah, and we talk about high versus low volume, right? And that's based on the charted criteria. But how do we actually use that now?
But I agree that if you see low volume unconventional and you want to take one of the oligomet approaches where you're like doing SBRT, although STOMP and Oriole and some of those, well, one of them used conventional imaging and one used
I think like
choline
PETs.
PETs. But I think your point that you raised that you might do a PSMA PET there to kind of confirm or refute oligomet status makes sense.